You are so warmly welcome to this medal education session. And if this is the first time you've joined us, I hope you find this a really useful session for your clinical practice. Um, uh, this is the first of a two-part series on innovations in lipid management and ASCVD. Before we dive into our education today, it's really important that we share our disclosures with you, and I'm just going to bring those up on screen for you right now. So the learning objectives for this session, and this is the first of a two-part series, and I hope you'll join us next week as well. But for today, we've got two learning objectives. The first is describe the clinical significance of cumulative LDL-C exposure and its direct relationship with ASCVD progression and outcomes. And the second is to identify and stratify patients at elevated risk for ASCVD, including those with familial hypercholesterolemia, underserved populations, and high unmet needs. But before we dive into our education today, I'd like to understand where you're at in your educational journey in lipids and ASCVD. And what we've got are a few polls. The polls are framed around some clinical cases as well as some of the topics that we'll cover in today's session. And I'd love to hear your thoughts. So the first poll I'd love to hear your answers to is this. According to the Framingham Heart Study, what was the approximate increase in cardiovascular disease risk for participants with long-term exposure to the highest LDL-C levels compared to those with optimal LDL-C levels? Was it 2 times the risk, 3 times the risk, no increase in mortality, 5 times the risk, or 10 times the risk of CVD? If you could share your thoughts, that would be great. Thanks, everyone. Okay, super. Thanks for answering. I'll give you a few seconds just to do that. And if you're just joining us, we're doing some polls. You can answer them on the right-hand side of your screen. If you're joining on desktop, just click the little chat icon if you're joining on mobile, and you'll be able to answer those polls. If you're joining on one of the other channels, you will have to join on Medal next time to participate in our polls. Okay, the next poll is this. There are several key risk-enhancing factors for ASCVD that are not incorporated into the 2013 pooled cohort equations. Which of the following is one of these factors? Is it A, patient age, B, current smoking status, C, CKD, D, diagnosis of hypertension, or E, race? If you could let us know which of those you think is the correct answer. Great, thanks everyone. And we've got a third question for you, which is this. Based on 2018 AHA-ACC guidelines, which of the following patients is in a high-risk group for whom lipid-lowering therapy is indicated without the need for further risk estimation? A, B, C, D, or E? I'll give you a few seconds just to look at those answers. If you're just joining us, we can answer all of our polls. If you have missed them so far, you can scroll up in the chat box on the right-hand side, and you can pop an answer into each of those polls. Doesn't matter if you've missed one, just scroll up. You can pop an answer in to each one so you don't miss out. And if you're joining on mobile, just click the little chat icon at the bottom, and then you'll be able to see all of those polls. Okay, and then we've got 3 quick fire cases for you. And these hopefully frame the education for today quite nicely around a patient. And you'll hear of some of these patients later on in today's session as well. So the first is this. Mr. Smith, a 45-year-old male with a family history of premature ASCVD. His father died of an MI at 52. Is found to have an LDL-C of 165. He has not had his cholesterol checked in 20 years. Based on the LDL-C cumulative exposure hypothesis, what is the most significant clinical implication of this finding? A, B, C, D, or E? I'm going to give you a few seconds just to read that. And we're going to hear from some of these patients later on in today's session as well. So this is beginning to frame our conversation today around a patient. Great, thanks everyone. I'll just give you a few more seconds just to answer that. And then we'll move on to our second case. And our second case is this. Mrs. Jackson is a 55-year-old female smoker with a BMI of 33.2, a blood pressure of 140/80, and a GFR of 58, and an A1C of 6.2%. She lives in an underserved area with poor access to healthy food. Her 10-year calculated risk with the 2013 PCE is 9.1%. What is the most appropriate initial step? A, B, C, D, or E? I'll just give you a second just to share your thoughts. Don't worry if you don't know the right answer. We're going to cover each of these topics in our session today. So if you don't know the right answer, hopefully by the end of today's session, you will know the right answer. So don't worry, and we'll work through each of these as we go through today's session. If you've missed a poll, you can scroll up and answer each of those as we go along. Final case, and then we're going to begin to dive into our session. This is the final case. You reevaluate Mrs. Jackson using the PREVENT calculator, which yields a 10-year ASCVD risk of 5% compared to the 9.1% from the 2013 PCE calculator. The PREVENT calculator incorporates her GFR of 58 and her zip code or postcode, while the PCE does not. What is the most clinically sound interpretation and action based on this new information? A, B, C, D, or E? I'll give you a few seconds just to answer that. Great, thanks everyone. If you're just joining us, you're really welcome. I hope you find this session really helpful. We're just doing a few polls before we begin. We are framing our education today around a couple of patients, and we've begun to ask you some questions about those patients already. And we're going to dive into our education after two questions. I want to just understand before we start, how confident are you describing the clinical significance of cumulative LDL-C exposure and its direct relationship with ASCVD progression and outcomes? 1, not confident at all, right up to 5, very confident. If you could just share your thoughts on that. And then we've got one last question I want to ask you before we dive in. So thanks for being so participatory. This is active education. Before this education, how confident are you in your ability to identify and stratify patients at elevated risk for ASCVD, including those with familial hypercholesterolemia, underserved populations, and high unmet needs? 1, not confident at all, right up to 5, very confident. Super. Thanks, everyone. Okay, great. Thank you so much for answering those polls. Keep a lookout for some polls as we go through, because we've got a few questions we want to ask you during this session as well, and we'll have time for you to do that. If you've missed a poll, you can scroll through the chat box on the right-hand side. You can pop an answer into each of them. None of them close, so you can pop an answer in throughout the session. And the polls will pop up on your screen as we work through. It gives me great pleasure to introduce our speaker for this evening, who is Dr. William Callahan, and he's a family physician, and he's also the curriculum director of the Abington Family Medicine Residency Program, Jefferson Health. I'm going to hand straight over to Dr. Callahan.
I'm William Callahan, and today we're going to be talking about hyperlipidemia and recognizing high-risk patients for ASCVD. I have no disclosures. So today we're going to describe the clinical significance of cumulative LDL exposure and its relationship to ASCVD. And we're also going to identify and stratify those patients at elevated risk for ASCVD. So ASCVD, leading cause of death worldwide, causing about 1/3 of all deaths across the globe. Now, if we were to, instead of saying 1/3 of all deaths across the globe, instead of 32% of all deaths across the globe, we could break it down into those who die of ischemic heart disease, which would be close to 16% of all death across the globe. Or we could say close to 12% are dying of strokes across the globe. So these are things we see fairly commonly in practice. And, you know, if there's anything we can do to prevent those from happening, it's something that we do need to pursue. When we talk about cholesterol, which we know is the basis of plaque, There's endogenous and dietary. Endogenous is made in the liver, and it requires HMG-CoA reductase, which we're all familiar with due to the medications we use to treat cholesterol. Looking at cholesterol and the way it comes into our blood. So we eat something that has fat, right? It's broken down, becomes triglycerides, and chylomicrons take that to the cells who want it. So think muscle cells, think fat cells. They will take it there, they will transport it there, and then the chylomicron remnants will then make their way to the liver, where the liver will then make it into a very low density lipoprotein, or they will discard it. Either way. But if they make it into a very low density lipoprotein that now has cholesterol particles attached to it, they will then leave the liver and make their way around the cells that want cholesterol. So cholesterol in and of itself is not necessarily a bad thing. You know, cells do need it. So if we think of our cell membranes, they do require cholesterols. It's more just that in overabundance, it becomes a problem. So very low density lipoprotein, VLDL, will start dispersing its cholesterol particles. And as it does that, it becomes an intermediate density lipoprotein and ultimately ends as a low density lipoprotein, which will go around and disperse cholesterol particles. HDL does the opposite and finds cholesterol that really is somewhere it shouldn't be and brings it back to the liver. A few things to know about cholesterol. So these lipoprotein products do contain ApoB100. It's found in all LDL particles, and this really becomes important because it allows LDL to bind in the body. We're able to measure ApoB100, and that allows for us to say, is an LDL particle dense or is it fluffy? Think of it this way. Think of a suitcase, right? You have one suitcase, that's your LDL, your low density lipoprotein. Is it really crammed with clothes, right? You really densely packed it, or did you pack just one or two outfits and it's fairly light? That's how we can look at our LDL and our ApoB100, because each cholesterol particle carried by that LDL will have its own ApoB100. So if it's densely packed with cholesterol particles, it's going to have more ApoB100 than if it's not densely packed. If it's quote unquote fluffy, then it's only going to have, you know, a few ApoB100s because there's not many cholesterol particles to that low density lipoprotein. And then there's lipoprotein A. So lipoprotein A is LDL-like, but it is separate. This is not really affected by lifestyle. This is something more genetic, and it is something that increases risk for heart disease. So this is something that we should pay attention to, particularly when we are risk stratifying patients. If you do have an lipoprotein A level, this is something that we should be discussing with patients, assuming we have that information. So LDL flows in the blood, but in overabundance, where we have more LDL than necessary, it can start becoming trapped in blood vessel walls. Now, the immune system recognizes this, recognizes it shouldn't be there, and macrophages then engulf the cholesterol. This, of course, then really bloats the macrophages. They become fatty and foamy, and they then are known as foam cells. And this is the quote unquote bad cholesterol because this is the basis for plaque. HDL does the opposite. HDL recognizes this and starts taking this back to the liver. So HDL, that's why it's known as good cholesterol, because HDL is taking it back to the liver and away from areas where it could really cause some trouble. When it comes to plaque, so these foam cells and plaque is starting to build up, it's not uniform across a blood vessel. It's like looking out at a mountain range. You have peaks and you have valleys. So, you know, when I'm describing this to patients, I'll say, look, you look at a blood vessel, you might have a lot of plaque in this one, and you might not have so much plaque in this one. And we know this. We do imaging studies, calcium scores, ultrasounds, and we can see which arteries are more affected than others. The problem really becomes that when plaque is disrupted and it breaks away, the body then responds in any way that you would expect. It tries to clot it off to stop any further damage. And that clotting it off can then lead to ischemia. Here's a clinical scenario. So Mr. Smith, a 45-year-old male, presents for his annual physical. On family history, he says that his father died of an MI at 52. When you take a social history. He works a high-stress job, often eating fast food, and he's a former smoker. He quit 5 years ago, and you applaud him on this, of course. He did do blood work. LDL is 165, and then he tells you that he can't remember the last time he had blood work. It's been at least 20 years. So given Mr. Smith's family history of premature ASCVD, what is the most significant clinical implication of his high LDL level being present for an unknown but likely extended period of time? A, his current LDL of 165 is his primary risk factor. B, his high-stress lifestyle is the only factor requiring immediate intervention. C, he has accumulated a high lifetime burden of LDL exposure, which is a major driver of atherosclerotic plaque progression. D, his risk is likely to decrease because he quit smoking 5 years ago. Or E, a single measurement of LDL is sufficient to determine his long-term risk. So I'll just get everyone a little bit of time here to answer. Okay, great. So the answer here is C. He has accumulated a high lifetime burden from his most likely regular LDL level. And I say regular in the sense of it likely hasn't changed. He's not giving us any reason to believe that his current period in life is very different than it's been in the recent history. So his level of 165 is likely where it's been hanging for most of his adult life. And that's a problem because it's elevated, and that elevated LDL is most likely causing trouble. Studies do show that if we address the LDL, if we can drop it by about 40 points, we can decrease the risk of major adverse cardiovascular events by upwards of 22%. So that's really important for us to know, because when we're sitting with patients and talking with them, we can discuss this and we can say, this is why you might want to consider medication, because your risk is high of developing an event and we can lower that. But it also leads to the idea that LDL, if we can lower it at all or even earlier, we can help decrease the likelihood of these events. So again, atherosclerosis is the buildup of plaque. And as LDL becomes trapped in the blood vessel walls and it starts building up, this is what creates a problem. And then again, as that plaque breaks off and then the body tries to cut off the remnant of that plaque, this can lead to ischemia. So it's really problematic that this is occurring. Further complicating this is that there is a long asymptomatic period, and the studies bear this out, where atherosclerosis is building up, and we're most likely not doing a great job of addressing it. When we think that we're talking to patients and we're talking to them about, their cholesterol, generally starting at least after the age of 30, if not 40, where we're checking these levels and we're talking to them about how to lower it, we're often not considering that plaque is building up in those years, and it's not until later in life that it becomes much more clinically significant. And this is just an example, right? The plaque starts building up. It's not at all blocking blood flow, but over time, it starts to decrease the amount of blood that can go by. And then once you have an event where the plaque ruptures, the body tries to clot it off, that's where you run into trouble. So here's a few studies looking at this. We have the Swedish cardiopulmonary bioimage study. This looked at 25,000 people, middle age, so 50 to 64, and they were healthy. They had no known coronary artery disease. And they did coronary artery calcium scoring on these patients and found that just under half, 42.1%, had plaque on imaging. So it's really significant because these are patients we see all the time, and we're talking to them about, you have an elevated LDL, you have a low HDL, we might want to address this. And here, just under half, so just under 1 in 2, had plaque on imaging. And of those, 5.2% actually had a fairly significant stenosis of greater than 50%. So again, these people only found out that they had plaque because they were in the study. There was no clinical reason to check a calcium score. And again, recognizing that plaque takes time to build up means that this was happening earlier in life. The Framingham Heart Study also suggests similar. The Framingham Heart Study, of course, following people over time, suggests that people with the highest LDL level and having that level over time were carried 5 times the risk of CVD and were actually at 4 times the risk of total mortality. The cardio study, a study I really like because it looks at younger people and follows them over time. So individuals 18 to 30 were chosen for the study, and these were healthy young adults. They had no known heart disease. And what it found was that those with the highest cholesterol and the time in that range were the most likely to go on to an event 40 years later. An event was heart disease, CVD, heart failure, death caused by ASCVD. And we also know this just from our patients with familial hypercholesterolemia. This, of course, is genetic. And we know that they are born, there's a problem with the ApoB receptor. So because it's not functioning well, and LDL therefore just hangs out in the blood, you end up with a higher level of LDL than you would normally expect the patient to have. So they are born with this, therefore their cholesterol ends up high very early in life and it stays high. When untreated, those in their 30s carry up to 3 times the risk of CAD compared to the general population. So just recognizing how our patients with familial hypercholesterolemia, how their pathophysiology works, further backs up this idea that LDL exposure over time is a problem. How do we then approach our patients, right? Because we're talking to them about cholesterol and we're talking to them about LDL and we're talking to them about how this is a problem over time. Well, we want to focus on prevention, and the big one's going to be primary prevention, especially if we're talking to younger people about this. So if I'm talking to someone who's 20, 25, it's really difficult for them to understand how cholesterol is important because they are looking at it as, well, my parent who's, 50, they take cholesterol medicine, but this individual who's 25, they don't see it that way, right? They're not seeing the day-to-day consequences of high cholesterol. But this is where we want to sit down with that patient and we really want to counsel them on how to address it and how to prevent further buildup. What we want to try to avoid is needing to have a secondary prevention discussion, right? We want to try and avoid where someone has an event and then, of course, sitting with them, trying to avoid them from going on to have an additional event. Obviously, if someone already has ASCVD, we do need to focus on secondary prevention, but the goal here is primary prevention, trying to avoid an event in the first place. And it's all through shared decision-making. We want to sit with the patient, we really want to counsel them on cholesterol, and we really want to talk to them about what are the options for treating it, and we want them to, with us, buy into the treatment, right? That's the shared decision-making. So back to Mr. Smith. When counseling Mr. Smith, which of the following is the most effective way to explain the impact of a sustained high LDL level of 165? A, focus solely on his current LDL value and the immediate need for medication. B, tell him that a healthy diet and exercise alone will reverse the plaque buildup. C, explain that atherosclerosis is a cumulative process and that lowering his LDL now will reduce his total lifetime burden, even if he has had high levels in the past. D, advise him that since he is asymptomatic, there is no urgent need for intervention. Or E, recommend that he only check his LDL every 5 to 10 years, as that is the standard guideline. So we'll give everyone just a little bit of time to answer this. Okay, good. So the answer here is C. We want to explain to him that his LDL being elevated for an extended period of time is not great and may have, caused some plaque to build up. It certainly increased his risk of it doing so. However, if we can decrease it now, moving forward, his lifetime risk starts going down. So now to talk about ASCVD and really our clinical decision making. So what we do with our patients is we break them down into groups, right? We look at what is their risk. And the recommendations are very clear. For those who are very high risk, those with clinical ASCVD, those with diabetes, those with an LDL at or greater than 190, they should be on lipid lowering therapy, right? This is what the recommendations all recommend. Of course, we do need to talk with our patients. We need to counsel them no recommendations tell us not to do that, but they're all very clear that our patients should be on lipid-lowering therapy if they fall into these groups. Where things get more complicated are when we're using our risk calculator to determine low, intermediate, and high risk, right? So our patient with diabetes, we don't need to risk calculate. We know that they should be on lipid-lowering therapy. But many people, they don't fall into a group where they immediately should be on lipid-lowering therapy. And that's a good thing, right? We're happy that our patients overall are healthy, right? So that's good. For our patients, we're then going to need to risk calculate, and we're going to also need to consider risk enhancing factors, because these calculators, they don't consider everything. And that's really where we need to sit with our patient and we need to discuss what may increase their risk. So most of us are using the 2013 PCE calculator, and this is what it looks at. It looks at cholesterol levels. It looks at whether the patient smokes, whether they're diabetic, whether they're hypertensive. And then it looks at their age, their sex, and their race. So there's a lot left out here that increases a patient's risk that it doesn't consider, right? It doesn't consider, are they pre-diabetic, right? Do they have a general inflammatory process? There are many things it doesn't look at. Now, many of us use this calculator because it's built into many EMRs, right? It's built into my EMR, and it's very, very convenient when you're doing that. I realize that we're all short on time and that anything that can help us is really, really good. But it's built into EMRs. It pulls the data out of the EMR and it just gives you the number. So it's really easy to sit there, look at the number when you're with the patient and see what is their risk. So, we just need to consider, well, what other risk factors are present on that patient? Because we do need to recognize that this is leaving a lot out. So a clinical scenario, Mrs. Jackson, a 55-year-old white female, presents for a follow-up visit, during which she requested routine blood work. Her family history is unknown. By lifestyle, she's a quarter-pack smoker a day. She's trying to stop. She has social alcohol use. She defines it as about 1 to 2 drinks a week. No drug use. She lives alone in an apartment in a historically underserved area. As you talk with her, she says she doesn't go to a gym because she can't afford it, and that there's no nearby parks for her to walk to. And she doesn't really have any grocery stores that she can get to nearby. It's what is considered a grocery store desert. She works as a cashier. Her diet, without having access to a nearby grocery store, is pretty heavy in fast food. At the visit, her blood pressure is 140/80. Her BMI is 33.2. Labs show an LDL of 142, an HDL of 35, an A1C of 6.2, and a GFR of 58. When we use the 2013 calculator, her ASCVD risk is 9.1%. So based on this, what is the most appropriate initial recommendation for this patient? A, initiate a high intensity of statin immediately to reduce her LDL by at least 50%. B, start a moderate intensity statin and set a goal to reduce her LDL by 30%. C, focus solely on lifestyle changes and reassess her risk factors in 1 year. D, begin a shared decision-making discussion to consider her risk factors and preferences for statin therapy. Or E, her risk is too low to warrant any intervention at this time. So give everyone some time here. Okay, good. So the answer here is D. So she falls into that intermediate risk category, which means we're going to begin a shared decision-making discussion looking into her risk factors and her preferences for statin therapy. So looking at the recommendations, those who fall into a low risk category, less than 5%, focuses generally on lifestyle modification. So this is going to be, let's look at your diet. How much fiber do you eat? Do you eat a lot of processed carbs, a lot of processed fats? Do you get good exercise? Are we addressing things like smoking? Are we addressing stress, good sleep? There's a lot to lifestyle. So we really want to sit with our patients and have the time to go over lifestyle with them. Where the group becomes problematic is the intermediate risk group, 7.5 to less than 20%. Because Patients often don't want to be on medication, but the question is, should they be on medication? Of course, it's easy for us just to put everyone on medication, but that doesn't mean it's the right decision. The official recommendations are to have a shared decision-making discussion with the patient, discussing their risk factors, discussing our goal to have their LDL below 100. And if we do start a statin, it should be moderate intensity to reduce the LDL by 30%. I find these visits can be, time consuming because you're sitting with the patient and you're really going over with them, why you want to lower their cholesterol. Cholesterol can be very difficult for patients to comprehend. I can give them a blood pressure cuff and they can see their blood pressure. And patients associate high blood pressure with problems. I can also give them a glucometer and they can check their blood sugar and they associate a high blood sugar with problems. And often they don't feel well. Often they'll say, I'm thirsty a lot when my blood sugar is high. I feel really tired when it's high. Same with high blood pressure. They'll often report headaches. But high cholesterol is very different. Patients don't have that same wherewithal about it. They don't say, I feel bad when my cholesterol is high. And it, of course, does take time for it to change. So it becomes a lot more difficult to have that discussion because patients don't understand it like they understand high blood pressure and high blood sugar. High risk is a lot clearer. For patients whose risk is above 20%, it's recommended to start a high intensity statin to reduce LDL by at least 50%. When we look at goals with diabetes, you want to have it below 70, your LDL below 70. Goals are starting to shift. So for established ASCVD and a high risk of recurrence, goals are starting to suggest that we should actually aim for a very low LDL below 55. This coming out of the American Association of Clinical Endocrinologists, and are starting to see people starting to do this. So just something to keep in mind. If you're unsure which recommendation to turn to, I think it's safe to say that below 55 is fine to do based on the newest recommendations. Young adults. So when you check someone under the age of 40, which of course are not who the recommendations were made for, so those adults 20 to 39, you still want to have a discussion with them about their lifestyle. Now, obviously, if they fall into a high-risk group, they have diabetes, their LDL is above 190, right? Then you're obviously going to start them on a statin because they should be on, or lipid-lowering therapy, excuse me, because they should be on it. For those 20 to 39 who have elevated cholesterol, but otherwise, they don't fall into one of those high-risk groups, you're going to talk to them and you're going to, again, have a shared decision-making discussion about, are there reasons they should be on a cholesterol-lowering medication? Because it is possible that they should be. So again, we're going to have that shared decision-making discussion with them. For those with familial hypercholesterolemia, we need to identify who they are because not everyone knows they have it. But if you take a thorough family history and you recognize numerous people who have heart disease, particularly heart disease early in life, that really should raise the antenna that this exists in the family. People with familial hypercholesterolemia carry a twofold increased risk of CAD, even when we get their LDL down below 190. Recommendations are to screen children with a known family history of familial hypercholesterolemia. And if their LDL is above 160, we should consider starting them on lipid-lowering therapy. And of course, anyone with an LDL above 190 should be started on lipid-lowering therapy, regardless of whether they have this running in their family or not. So our risk calculator that many of us are using, our 2013 risk calculator, there's a lot of questions about it, and it's all because the data used to formulate this calculator is just a little dated. While 25,000 individuals were included in these studies, it's a little dated coming from the 1980s and earlier. And so the question really becomes, is this relative to today's world? Or are there things that weren't particularly considered when forming this calculator based on the data used to formulate it? And studies do bear that out. Studies suggest that it actually can overestimate risk by upwards of 20%. And there are things that it doesn't look at. So not factored would include metabolic syndrome, which we see a lot of today. Chronic kidney disease, again, we see a lot of this. persistently high triglycerides, abnormal ABIs, social determinants of health. And social determinants of health is a really big one because this is something that is ever present in today's world that we really do need to consider. When we look at social determinants of health, and I'll explain what these are, the social and community context, what is our patient non-medically, what does our patient look like? So what is their income and what type of access do they have to what would help their life? And what is the community they're living in? What does that look like? Again, what type of healthcare access do they have? Can they afford healthcare? Can they afford to get to healthcare? What is the neighborhood and built environment? So this would be, does it have parks? Does it have grocery stores? Is it safe? Or even if it is safe, do they feel safe in it? Economic stability, right? So again, this refers to, they have a job and can they afford what they need, and education access and quality. So if we had to look, what are the most important on an individual level, it's going to be, what is the patient's level of education? What is their income, and are they employed? Those are going to be the biggest ones affecting a patient. The lower their education level, the lower their income, and if they are unemployed, those all bode poorly for the patient's social determinants. On an area level where the patient lives, the same is true. The lower the level of education, the lower the income, it's going to mean things in that area are likely to be worse. So are there parks? Maybe yes, maybe no. Does the patient feel safe going outside? Maybe, but maybe not. So things for us to consider, are there grocery stores around, or is it a grocery store desert? If it is a desert, then where is the patient going to get their food? Maybe they're driving out of the neighborhood if they have a car, if they have access to that, and if they can afford gasoline. Maybe they're taking public transit, then can they afford the time it takes to take the public transit? So a lot of questions come up. And I think the social determinants of health, this becomes a big problem for us because it's not as easy to address. Unfortunately, it's important, right? So studies indicate that the risk of ASCVD events are up to 31% higher in those with the highest cumulative social determinant of health burden. So again, we know this is really important for our patients, but the question then becomes, how do we address it? What is the most effective way for us in medicine to address these social determinants of health? When we look at something like high cholesterol, it's pretty clear we have guidelines that can really guide us. We have recommendations, and it's pretty clear what we should be doing. But social determinants, they're a little more difficult to address because it's not so clear exactly what to do. But studies do suggest what would help. So health team education is one of those things. In other words, if we're going to screen for social determinants of health, right? One, how do we ask that? And then do we know how to address that? So it's all about educating ourselves and who we work with, having diversity of the healthcare team. So if a patient isn't comfortable opening up to us, maybe they are comfortable opening up to someone else on the team. Again, in healthcare, we work as a team. So having diversity in the team is good. Equitable and understandable language is really important because patients need to be able to understand what it is we're saying to them. I'll never forget a patient I was seeing in a rehab, and their spouse came up to me and said, please do a sepsis test. Sepsis was ultimately what resulted in the patient going to the rehab in the first place once they were better. But the spouse was very worried that the patient had lingering sepsis. The spouse didn't understand that sepsis is more, a process that a patient ends up in due to an infection, and that there's no real one test just to tell us whether they're septic. So I sat and explained that to the patient's spouse, and they really had difficulty understanding it. It led to a very long discussion about how there's not one test. This is something that, really it's looking at the patient overall. And the thing is, we do this in many different situations, sepsis, but many other situations where we need to recognize that the language we're using needs to be understandable to the patient and the patient's family so that they can recognize and understand what we are telling them. Technology is another. So technology, thankfully, is growing. And I recognize that it is one of those things attributing to physician burnout, but it is important to our patients. Patients aren't always able to get away from work, stand on the phone, in a corner at their job and wait for 30 minutes while they're waiting to get scheduled for an appointment, or waiting, to ask a question. I know when I call my own primary care doctor, I'm often put on hold for an extended period of time because these are busy people, and I recognize that. But thankfully, I can at times find the time to get on the phone. It's a lot easier for a patient, though, to send a message on a patient portal and just say, hey, quick question about this medicine you're putting me on. Or they can look and see when we have openings in our schedule and just put themselves in the schedule. And if we feel they need an appointment, it's easy to say, hey, I have an opening, this time, this day. Why don't I give it to you? And we just send that information back. And then finally, community engagement, which a lot of places are starting to do. They go to neighborhood fairs, they set up a booth, and it's just advertising, hey, here's an office, and this is what we do here. Maybe doing blood pressure screens or blood sugar screens. These are great ways of engaging the community and also building trust in the community. So then the question becomes, well, is there a calculator that includes social determinants of health, recognizing that it's really important? And there is. In 2023, the Prevent calculator came out. This was built on cohort data coming from over 300 million charts and EMRs. It does not include race, but it does factor in things like kidney function and microalbumin and zip code. Zip code is the way that this calculator gets at social determinants of health. Again, it's not going to be perfect, right? You can have a person who on an individual level is high risk by social determinants living in a zip code that in and of itself might not be high risk, but overall studies do indicate that this calculator does not overestimate risk. So overall, it seems like using zip code is helping. When we look at the Prevent calculator and what it includes the addition of GFR. It asks about specific medications the patient is taking. It asks about A1C, trying to capture those people with prediabetes. It asks about microalbumin. So between that and GFR, really trying to capture people with CKD. And again, zip code. So back to our clinical scenario with Mrs. Jackson. Again, she has an unknown family history. She does smoke. She has a high stress job, it sounds like, and she lives in a historically underserved area. She does have an elevated LDL, an elevated A1C, a low GFR, and she is hypertensive. Okay. So let's compare the two calculators for Mrs. Jackson. The 2013 ASCVD risk calculator put her at 9.1%. The Prevent calculator, which gives us both 10 years and 30 years, put her at 5% and 22%. So really allows us to sit there with our patient and really have a great discussion with her about next steps, about what we should be doing to lower her risk as we move forward. So in summary, LDL exposure over time influences plaque development. The decision to treat is based on risk. Consider, does the patient have existing ASCVD? Do they have diabetes? Do they have familial hypercholesterolemia? And of course, other risk factors. Patients 40 to 79 should have a calculated risk score, and there should be shared decision-making taking place with consideration to the patient's risk factors. Thank you.
What a fantastic piece of education. Thank you so much, Dr. Callahan, for that incredible session. Before we dive into questions and answers, I'm going to pull up on the screen a really important QR code, which is going to allow you to claim your CME certificate if you are attending. So you might want to scan that and you can give us some feedback in the evaluation. You'll be able to quickly claim your free CME certificate. We're really passionate about making these sessions as helpful to you as possible. So we appreciate the feedback, and hopefully you appreciate that free valuable CME certificate. Okay, we are going to dive into some questions, and we've got some great questions from our audience across Metal and our other channels that I am going to be able to pose to our fantastic speaker today, Dr. Callahan. Dr. Callahan, thank you so much for joining us.
Yeah, thank you. Thank you for having me and allowing me to be here. Yeah, so I see some of the questions right here. Oh, sorry, it just took over my screen. There we are. So we'll jump right in. Let's see here. So one of the questions, the concept of LDL exposure, cholesterol years, of course, which we talked about. How can we best translate this concept into a compelling message for younger people? Right. Yeah, so younger people are I find the biggest barrier when it comes to talking about cholesterol, right? Because they have that sense of invincibility. I think talking to younger people, and when I say younger, we'll use maybe 20s to about 30, early 30s. Even talking to them about, in certain infections, talking about giving them certain vaccines and whatnot, it can be a barrier because there's this sense of, I don't need it. I'm very healthy. I don't need this. But what I tell them is that this cholesterol builds up. It's like putting butter on bread, right? You put it on, it doesn't go away. So all I'm doing is over time, I'm just adding it on, adding more and more on. And that's how I have that discussion. Some of the time people do opt, to really focus on lifestyle change, which is evident when I recheck their cholesterol. I do, unfortunately, infrequently, I do, for very high risk patients, get them onto medication. In between, I do then further risk stratify patients. Let's say their cholesterol is really high. Maybe they're like 33, and I'm really worried. Maybe there's further family history that really concerns me, but no obvious family history of FH. I'll do things like a calcium score to further risk stratify. Once they see a calcium score come back positive, that really changes the discussion. And it's no longer this, well, I don't need medication. It's more of a fear thing now that they have. And then that really changes the approach. Not that I'm trying to scare patients. It's more just they can now quantify that there's an issue going on. And then a question here about lipoprotein A. Yes, it's genetic and it is a risk factor. In which specific patients? So this is when a patient has high cholesterol. I'm talking to them and they do have a family history or they have a family history and, I usually think parents, but perhaps it's a sibling who has had a heart attack or a stroke and their cholesterol, let's say, is maybe 120, 130 LDL and I'm trying to risk stratify them. And I say, why don't we start a low dose of medication just to offer you a baseline protection? But let's check this because, yes, you have this family history. Let's check an LPA just to see what it looks like. I find in practice that a lot of patients don't want to check it. And the interesting reason here is that they're worried about cost of the test. I know that we have, different people partaking in this from all different countries. But, in the United States, cost of healthcare is a major factor. And so a lot of people turn it down, but we have checked it. And, a lot of times just that discussion in higher risk patients. Question here about Mrs. Jackson and the social determinants health, right? What are one or two? Yeah, so this is a big one, right? Because we go to med school, we learn how to treat different health problems, but social determinants are not one of the easiest things to treat. So I'm really fortunate. Where I practice, we have a social worker and she works with us. So we screen everyone for social determinants of health. We ask them, was there a time where you couldn't afford medication, where you couldn't afford food, where you couldn't afford transportation, where you couldn't afford your electric bill, your gas bill? That's what we screen for. Now, I would say if you have a social worker, then it becomes pretty clear that, you just need to work together to figure out how best to address these. So our social worker we'll plug people in with our food pantry where we help people get, in this case, free food, right? And we'll plug them in to get discounts on their electric bill, gas bills. But if you don't have that type of setup, and I understand that many don't, I would focus on what we can impact. So I know here, where I practice, if I didn't have a social worker, there are programs that will help lower the cost of medications. So if I know that a patient is struggling with that, I would then plug them in and say, okay, here's this card you can use and it will take money off of the cost. And I would also keep in mind when I'm prescribing, let me prescribe something that is affordable or is something that they can get a discount. The other is to recognize where can patients get healthy food for a good price, right? That's something that because we all do food shop, I think we all learn where can someone go. And I will have those discussions with patients. I'll say, you get that pushback, oh, I can't afford organic food. And then I'll point out, well, we have an Aldi, which near where I practice, they sell organic food for a very reasonable price. And I'll point out, they're very reasonably priced. Have you ever considered going there? A lot of times the answer is no. Like a lot of times it's just people don't know this and it's just us educating them. So that's how I would approach that. And then a follow-up question here. So with patients with FH, the key red flags, these scare me actually because I have had people with FH and I've had it where they don't recognize it, and then, in practice, I do. So they come in and oh gosh, I have a nightmare about the last patient I saw with this. He came in, he was mid 30s, I want to say 35. And I always take a family history when I meet a patient for the first time or I'm doing their first physical. And when I am taking the family history, I specifically ask multiple questions that all point to heart disease. So I'll say, has anyone in the family had a heart attack? Anyone diagnosed with heart disease? Anyone have a stent? Anyone have bypass? A sudden heart event? I'll ask all those sorts of questions because I have learned that if I say heart disease, people often will say no. And then as we move along, they'll say, oh, yeah, my father had a stent. In this case, his father died of a heart attack at 40, and his brother also died of a heart attack at 38. So it was pretty clear that this was a genetic thing going on. His EKG looked fine and he wasn't worried himself. However, he smoked. And so knowing that, I was really worried. And I sent him to cardiology and they were working him up. Unfortunately, while they were in the process, he did have a heart attack. So, confirmed our suspicions. He survived and he's still doing very well, but it still scares me because a lot of people come in and they don't know that. Um, and then a follow-up question here about, right, not feeling the cholesterol. So the analogy. So, that butter on bread analogy is a good one. The other one I'll use is I'll describe just the buildup of plaque like a mountain range, and I'll say, it builds up and as those mountains get higher and higher, it's a lot easier for there to be a break at the top. It just can break off and that leads to trouble. I know the analogy isn't fully accurate with regard to biochemistry in the body, but patients can understand that. They understand that, oh, okay, that makes sense, right? Blood is coursing by and that mountaintop that's really pointed and jagged can break off and that can create trouble and that can block off blood flow. Again, I recognize it's not fully medically accurate, but patients understand that. And that's what I need them to do. I need them to be able to visualize and understand. So those are the two things. I think the butter on bread, though, most people get, so I don't usually have to go much further. Um, Regarding the emerging aggressive guidelines, right, okay, so I understand this. Are there any potential long-term safety concerns? Not that I've really seen. More of the studies I've seen focus on the medications themselves. So, we have the statin medications, the PCSK9s, bempedoic acids, that we're, really using in these patients. And most of the studies are referring to that. But I understand the question about, well, we do still need cholesterol in the body. But again, we're not bringing cholesterol to zero, right? The LDL never fully drops to zero. So I think, we're okay. In addition to that, we still are taking in when we eat, we are still taking in cholesterol. Remember, it goes both ways. You eat cholesterol that your body can use, and then you also make cholesterol. And most of these medications are affecting the cholesterol your body's making. So, I think we're probably okay, but, we'll see as more studies, come out, although right now most of them are focused on medication effects. What are the options for calculating risk in younger patients? Well, younger patients in general are low risk, right? Because they don't, unless they have, a really high risk condition like familial hypercholesterolemia, they don't have, all that time to build up, the LDL in their blood. So I'm not really aware of a calculator to look at them. I think it's more on us to sit with them and explain, um, what's what the risk is here and that we really do need to address it. And then it looks like the final question here, what is the LPA role in starting anti-lipid lowering medication? Right. So right now, There's no official recommendation to start a medication strictly for LPA. There is medication soon to come out within the next year, though, that targets LPA. And so I strongly suspect that that's going to change and that the recommendation is going to be not only to check, but that depending on the level, we should start treating. Right now, it's more putting the patient together. So if the patient falls into that intermediate risk group and now you have an LPA that's elevated, it's maybe we should start you on medication so we can lower your overall cholesterol, knowing that you're already high risk with an LPA that's elevated. But again, this is going to change over the next year or so because newer medications are coming out that target LPA.
Dr. Callahan, thank you so much for tackling so many questions in such a short space of time. We really appreciate it. And thank you so much for a really wonderful piece of education. Thank you so much for joining us.
Yeah, absolutely. Thank you again. Thank you, everyone.
And that just leaves me to thank you, our audience today. I hope you find today's session really helpful, really useful. We are going to be running another session on lipid care on October 30th. And in that session, we're going to have Professor Chris Cannon, who will be explaining how we can apply current cholesterol management guidelines, including LDL-C targets, adherence strategies, and treatment escalation approaches. And he's also going to be talking about how we can design strategies to overcome clinical inertia and streamline access to guideline-recommended lipid-lowering therapies for different patient profiles. If you find today's session useful, we'd love to see you at that session. I'll post the link into the chat. It's completely free, open access. You'll be really welcome to join us. I'm also going to bring up the QR code. So if you have not yet scanned that QR code to claim your CME certificate, just give that QR code a scan and you'll be able to claim a free CME certificate at the end of this session. I'll also post the link to that into the chat box as well. It's been a real pleasure to host you. I hope you found today's session useful, and I hope to see you at our next session soon. Thank you.